To talk about diabetes mellitus. This presentation was originally created for Bachelor of Physiotherapy students of Maharashtra University of Health Sciences, Nashik, but it will be very useful for MBBS students as well for understanding the concept of diabetes and for rapid revision. We'll be seeing first, before going into diabetes, we'll be understanding the sources of blood glucose, utilization of blood glucose, and regulation of blood glucose. And then we'll see the diagnostic criteria for diabetes mellitus, types of diabetes and pathology in diabetes, how do we screen for diabetes, and we'll see the complications, acute and chronic, of diabetes. Dietary carbohydrates are the main source of glucose in blood, and in a fed state, those that glucose is used for glycogen synthesis in liver and skeletal muscle. It can be oxidized to give energy. It can be used for synthesis of other monosaccharides and amino sugars. It can be used for synthesis of pentoses and NADPH, and excess glucose is stored as fat. If glucose is above 180 mg per deciliter, it is excreted in urine. 180 mg per deciliter is renal threshold for glucose. And then between meals, breakdown of glucose, glycogenolysis, is the source of blood glucose. And in fasting more than 8 to 10 hours, gluconeogenesis contributes significantly to glucose. Lactate, glucogenic amino acids, and glycerol, they serve as precursors for gluconeogenesis. But why is this important? Why is the blood glucose level important? We know that if blood glucose is more, if there is hyperglycemia, it is harmful. But hypoglycemia as well is harmful. Why is hypoglycemia harmful? Because hypoglycemia can affect can cause neurological symptoms. Brain needs glucose. Glucose is the obligatory fuel of brain. And if blood glucose levels fall below a certain level, then the brain won't get glucose, and that is why the body needs to maintain blood glucose above a certain level. And it is said that hypoglycemia, symptomatic hypoglycemia, is generally seen at blood glucose levels less than 50 milligram per deciliter. However, more than the absolute blood glucose levels, it is the rate at which the glucose levels fall that is what determines the onset of signs and symptoms of hypoglycemia, and also the adaptation of the body to the hypoglycemic state, and the threshold at which the epinephrine and glucagon and that response sets in order to try and increase the blood glucose levels. Diabetics have a increased threshold before which the epinephrine and glucagon will start to cause to cause the blood glucose to increase, and that is why diabetics hypoglycemia can go undetected, and that is why it is very important to manage monitor the blood glucose levels of diabetics, and especially those on insulin or those taking insulin secretagogues like sulfonylureas. So this graph just shows the sources of blood glucose. Postprandial, that is after meals, the dietary carbohydrates is a main source of blood glucose. In between meals, glycogenolysis is a main source of blood glucose. And in case of fasting beyond 8 to 10 hours, which is generally the overnight fast, gluconeogenesis is a significant contributor of blood glucose. Coming to hormonal regulation of blood glucose, there are several hormones that can increase blood glucose levels like glucagon, epinephrine, thyroxine, glucocorticoids like cortisol, and growth hormone and adrenocorticotrophic hormone. And the only hormone which counteracts the effect of all of these hormones is insulin. Insulin is the only hypoglycemic hormone in the body. Now, Diabetes. So we saw the sources of blood glucose, utilization of blood glucose, hormonal regulation of blood glucose, and now we come to this group of disorders of abnormal carbohydrate metabolism, sharing in common the clinical finding of hyperglycemia, are together called diabetes mellitus. Diabetes mellitus is a group of disorders of abnormal carbohydrate metabolism, sharing in common the clinical finding of hyperglycemia. Hyperglycemia may be due to relative or absolute impairment in insulin secretion, along with varying degrees of peripheral resistance to action of insulin. How do you diagnose diabetes? If glycated hemoglobin is 6.5% of total hemoglobin or greater, or fasting plasma glucose of 126 mg per deciliter or greater, random plasma glucose 200 mg per deciliter or greater, along with symptoms of hyperglycemia like polyuria, polydipsia, unexplained weight loss, and 2-hour plasma glucose 200 mg per deciliter or greater during 75-gram oral glucose tolerance test. Now, previously, um, first we'll understand like why is there polyuria, polydipsia, and unexplained weight loss in diabetes. As we know that if the blood glucose is above 180 mg per deciliter, glucose is excreted in urine, and glucose attracts water along with it, causes polyuria that will cause volume depletion and cause polydipsia or increased thirst. And diabetes is a it's not that there is no glucose in blood. Glucose is there in the blood, but it is not able to enter the cells, and that is why there is muscle wasting seen in diabetic patients, because they are not able to utilize glucose for energy or for synthesis of proteins, etc. And previously, glycated hemoglobin 6.5% or greater was considered as definitive. Even if this was glycated hemoglobin was 6.5% or greater, you could say that the person is diabetic. But in recent times, it has been shown that glycated hemoglobin by itself cannot be taken as a diagnostic criterion for diabetes. You need to correlate glycated hemoglobin with fasting glucose or postprandial glucose or oral glucose tolerance test, because there are several conditions in which glycated hemoglobin will not be a reliable marker, and that is why you need to combine glycated hemoglobin with fasting postprandial glucose or oral glucose tolerance test, and also with hemoglobin electrophoresis or HPLC to detect abnormal variants of hemoglobin, in which glycated hemoglobin may be falsely low or high. And now, what is the difference between glycation and glycosylation? Glycation is non-enzymatic addition of glucose to hemoglobin, whereas glycosylation is enzyme-mediated addition of glucose to uh, any molecule. Enzyme-mediated addition of glucose is glycosylation, and glycation is non-enzymatic or spontaneous addition of glucose to hemoglobin. 2-hour plasma glucose 200 mg or greater during 75-gram oral glucose tolerance test. What is 75-gram oral glucose tolerance test? The patient is asked to have 75-gram glucose. After an overnight fast, you take their fasting sample, which is the zero sample, right? We'll explain in the next diagram. So after an overnight fast, you take their fasting sample, which is the zero sample, and then you give them 75-gram glucose in water, ask them to drink it for about 10 minutes, and after that, half an hour later, you take the first sample, 1 hour later, second sample, 1.5 hours later, third, and 2 hours later, fourth sample. So this was the conventional uh, oral glucose tolerance test. These days they just do 0, 1, and 2 hours, like only 3 samples instead of 5 samples. But you can even take 5 samples as it is shown here, that it will be able to better show the rise and fall of blood glucose. In half an hour, you will see that generally the blood glucose levels peak, and if there is no insulin resistance, or no diabetes mellitus, within 2 hours you will see that the levels of blood glucose will return to fasting levels, right? That is normal glucose tolerance. But if it is impaired glucose tolerance or pre-diabetes, the fasting blood glucose itself will be higher than 100, and after 2 hours the glucose levels will not come back to normal levels, or they may not even come back to the original fasting level. It may still be higher than the fasting glucose. And if it is diabetes, fasting glucose levels will be above the threshold for diagnosis of diabetes mellitus, and 2 hours after the 75 gram glucose, that blood glucose levels will be above 200. Yeah, so that is about the oral glucose tolerance test in a normal individual, in a individual impaired glucose tolerance, and an individual with diabetes. So what is the criteria for normal blood glucose, impaired glucose tolerance, and diabetes? So these are the diagnostic thresholds. Normal fasting glucose less than 100 is normal. If it is between 100 to 200, 100 to 125 milligram per deciliter, it is called as impaired fasting glucose, and more than or equal to 126 milligram per deciliter is diabetes mellitus. 2-hour plasma glucose is either 2 hours after a full meal or 2 hours post oral glucose tolerance test. If it is less than 140 milligram per deciliter, it is normal. 140 to 199 milligram per deciliter is known as impaired glucose tolerance, and um, more than or equal to 200 milligram per deciliter is diabetes. So impaired fasting glucose is generally also accompanied with impaired glucose tolerance, but sometimes the fasting glucose may be normal, but glucose tolerance may be impaired. That is, after fasting glucose may be between 70 and 100, but after a 75 gram glucose tolerance test, postprandial may be between 140 and 199. And that is why these two are slightly different. And these two together are also called as pre-diabetes, and they have an increased risk of diabetes mellitus. So in case of impaired glucose tolerance and HbA1c, you can see these are the values. In case of impaired glucose tolerance on fasting or random plasma glucose values, diagnosis of diabetes can be confirmed by repeating the test on another day or by performing an OGTT or HbA1c. So if you have any of these values in the pre-diabetic range, right? Right, if you have the fasting or the 2-hour glucose or HbA1c in pre-diabetic range, and if you want to know if the patient is diabetic, then you repeat the test on some other day, or you do additional tests. Like if fasting is in pre-diabetic range, then you can do a 2-hour oral glucose tolerance test. You can check the HbA1c. If HbA1c turns out to be more than 6.5, 2-hour oral glucose tolerance test, 2-hour glucose turns out to be more than or equal to 200, then the person is diabetic, even though fasting is in the impaired fasting glucose category. HbA1c. HbA1c is glycated hemoglobin, as we saw. That that gives a idea of blood glucose control over the past 90 days. Even though hemoglobin in RBCs have a lifespan of 120 days, but HbA1c is a reliable marker of blood glucose of about past 3 months, because HbA1c is highly affected by the past 30 days of glucose control. And as the RBCs age, they contribute lesser and lesser to the glycated hemoglobin portion. And that is why, even though the lifespan of RBCs is 120 days, the HbA1c is a reliable marker of blood glucose levels for only about 90 days or 3 months. And but it still is better than fasting glucose, isolated fasting glucose or postprandial glucose values, because they are affected by a lot of short-term factors, like what has been consumed. Like if you eat a lot of sugar, your fasting may be high, but if you are not a diabetic, your HbA1c may be 5.4, 5.5, but just because you had a lot of sugar at once, you had a higher fasting, you had a higher postprandial glucose, or if you were stressed or something, your fasting glucose may be abnormal because of higher cortisol, but HbA1c will still be in 5.4, 5.5, like in the normal range. And that is why it is a more reliable marker than isolated fasting or postprandial values in diagnosis or management of diabetes. However, HbA1c However, HbA1c is not a reliable marker in case of hemoglobinopathies or normal hemoglobin variants, as we saw. And hemoglobinopathies are associated with hemolytic anemias. Hemolytic anemias have a decreased RBC lifespan. HbA1c is also falsely high in polycythemia and post-splenectomy, and it's not a reliable marker in chronic liver disease due to increased erythrocyte turnover. So, what are the major metabolic alterations in diabetes mellitus? There is some degree of insulin deficiency, either absolute insulin deficiency because of decreased insulin secretion or relative insulin deficiency because of insulin resistance. So there is decreased glucose uptake by cells, and as a result, uh, plasma amino acid levels are increased because there is also decreased amino acid uptake by cells because insulin also is responsible for having amino acids transported inside the cells. And there is a relative hypoglycemia in the sense that cells feel that there is no glucose when there is a lot of glucose. And so they try to, the gluconeogenesis is uh, stimulated. When insulin is low, insulin inhibits gluconeogenesis. So when insulin is low, gluconeogenesis is stimulated and glycogenolysis is stimulated. Both of these increase glucose production, and decreased glucose uptake by tissues and increased glucose production lead to hyperglycemia. Insulin also stimulates lipogenesis. So when there is insulin deficiency, there is lipolysis, which increases free fatty acids in the plasma, and then they can be uh, triacylglycerol synthesis by the liver can increase. Peripheral lipolysis will happen, but the liver will synthesize more TAG, and that will cause hypertriglyceridemia. And hepatic ketone body production will also increase, leading to ketoacidosis. So basically, liver feels that there is, body feels that there is no glucose, but there is glucose, and so there is ketoacidosis, which is also seen in fasting. There is increased gluconeogenesis, which is also seen in fasting. Basically, it's just that a false alarm, and that is actually harming the body instead of helping the body. There are different types of diabetes mellitus: type 1, type 2, gestational diabetes mellitus, diabetes associated with endocrinopathies like Cushing syndrome or due to corticosteroids. So this will go away when the disorder is treated. Gestational diabetes mellitus also on termination of pregnancy or delivery, the gestational diabetes goes away in most of the cases. And genetic defects of insulin secretion may cause diabetes, like maturity onset diabetes of the young. Exocrine pancreas diseases can cause diabetes because of destruction of pancreatic beta cells, pancreatitis. But mostly, and there can be many other causes of hyperglycemia, which is diabetes. But we will be focusing on type 1 and type 2 diabetes. Type 1 diabetes usually happens in childhood or puberty. Symptoms develop rapidly. The patient is frequently undernourished, and it is a minority of cases of diabetes mellitus and has a moderate genetic predisposition. That is, you will hardly ever find any relative of that patient with type 1 diabetes. They may be mostly like, you won't find at least the first degree relatives with type 1 diabetes in most cases. It is characterized by beta cell destruction. It's an autoimmune disorder in which the body destroys beta cells, eliminating production of insulin. Ketosis is common, insulin is low to absent, and acute complication is ketoacidosis. There is no response to oral hypoglycemic drugs, obviously, because there is no insulin, and hence insulin is the mainstay of treatment. Whereas in type 2 diabetes, the age of onset, the patient is generally older with age more than 45 years. Symptoms appear gradually, it's insidious rather than rapid, and we'll see the pathogenesis in the sense that how type 1 diabetes develops and type 2 diabetes develops in the next slide. Obesity is usually present in type 2 diabetes. Even though the person may be slim, they may have increased visceral fat percentage. Slim person also can have type 2 diabetes because they will have increased visceral fat, which is called as central obesity. Or you may like he may be slim but he may have slight tummy because the visceral fat is more, which is called as central obesity. Type 2 diabetes accounts for more than 90%. This is an interesting thing that I need to tell you here, that the Japanese sumos, which are so fat, but they don't have diabetes. If you do their lipid profile, it will mostly come out to be normal because most of their fat is subcutaneous fat. It is not visceral fat. It is the visceral fat um, which causes inflammation and which predisposes to diabetes and coronary artery disease. Subcutaneous fat is harmless. So there are some people who are fat, but their glucose will be normal, lipid profile will be normal because that fat is subcutaneous. Visceral fat or central obesity is like if you are generally slim but just a slight belly, that is what is dangerous. Type 2 diabetes is more than 90% of diagnosed cases of diabetes. Very strong genetic predisposition. Like you must have seen type 2 diabetic patients, and you will usually find either the mother, father, or sibling, or some first degree relative with type 2 diabetes. And it is characterized by insulin resistance along with inability of beta cells to produce appropriate quantities of insulin. Ketosis is rare in type 2 diabetes because, okay, and plasma insulin is high early in the disease and low to absent in the longer duration. Why is it high? Because the body tries to overcome the insulin resistance by increasing the insulin secretion. But as the disease progresses, insulin secretion also goes down because the beta cells eventually exhaust. They get tired of synthesizing insulin, and so insulin secretion goes down, and eventually type 2 diabetes, if not controlled, becomes type 1 diabetes because the beta cells exhaust and they stop secreting insulin. Hyperosmolar hyperglycemic state is a common complication of type 2 diabetes. Obviously, they will respond to oral hypoglycemic drugs because there is a relative insulin deficiency. Beta cells are still functional. And unlike type 1 diabetes, where insulin is the mainstay of treatment, in type 2 diabetes, treatment is multi-pronged. I mean, surely you give a hypoglycemic drug or anti-hyperglycemic drug. You may even require insulin if the glucose levels or diabetes is not well controlled. But large part of the treatment is lifestyle changes, that is diet, exercise, reduction of risk factors, weight reduction, cessation of smoking. Why? Because smoking will increase your cortisol levels and that can lead to hyperglycemia. And that is why even for glucose tolerance tests, you're not supposed to smoke one day prior to the test, because if you smoke quite a lot and come there for glucose tolerance test, you may end up with having the blood glucose level showing impaired glucose tolerance, impaired fasting glucose, because of that smoking causing an increase in cortisol. Blood pressure needs to be controlled. This blood glucose, hypertension, diabetes, hypertension, and dyslipidemia, they are most of the time they are coexistent. Someone having blood pressure may also mostly have diabetes. Diabetics will generally have hypertension and dyslipidemia. They go together, and all of those then ultimately increase the risk for coronary artery disease. And C, dyslipidemia also needs to be treated. And all of these, this is the multi-pronged approach to treatment of type 2 diabetes. So we'll be discussing the temporal mode of development of type 1 diabetes. Initially, you can see that 100% of the beta cell mass is active, and these individuals have a genetic predisposition to autoimmunity against beta cells. And when some immunologic trigger, environmental trigger like viral infection or severe stress, because of that trigger, the body starts producing antibodies against islet beta cells. And initially, the beta cell mass starts going down, but blood sugar levels are still normal because the remaining beta cells are are able to compensate for the decrease in beta cell number and requirement of insulin. They are able to compensate by increasing the insulin secretion. But as more and more beta cells are destroyed, the remaining beta cells are not able to uh, compensate for the insulin requirement, and that is when there is pre-diabetes or insulin progressive impairment of insulin release stage 2, right? There is dysglycemia or pre-diabetes, and after about 80% of beta cells are destroyed by immunity, there is overt diabetes, as in the remaining 20% are not able to produce sufficient insulin to keep blood sugar levels in the normal range. So there is overt diabetes, which is stage 3, and the remaining 20% also will eventually be destroyed, and the patient will be completely dependent on exogenous insulin. But now something wonderful can happen. Say if the patient is diagnosed when 20% of his cells are still alive and they are started on exogenous insulin, the exogenous insulin relieves the remaining 20% cells which were overworked. They were overworked trying to compensate for the insulin requirement. And because you are giving insulin exogenously, they are relieved and then they get some rest and they start producing insulin. And sometimes that reduces the need for exogenous insulin. And in some cases, the person may achieve normal blood glucose levels even without administration of exogenous insulin. And this phase can last for about 1 or 2 years after diagnosis. This is called the honeymoon phase in type 1 diabetes. It can be seen in some patients, and uh, but it is temporary because the 20% cells also will be eventually destroyed by the immune system, and the person will have to be on insulin for his or her entire life. And that is why even if you see this kind of honeymoon phase where blood glucose like after giving insulin you're having hypoglycemia, so you reduce the dose of insulin, and with minimal dose you are having normoglycemia, and that is honeymoon phase. So you have to monitor the blood glucose levels very aggressively, like self monitoring of blood glucose at home. And if you see that the person is starting to develop hyperglycemia, that means the honeymoon phase is getting over and you need to increase the insulin dose. Now we'll see metabolic changes during development of type 2 diabetes. If I have to plot insulin secretion on the y-axis and insulin sensitivity on the x-axis, uh, initially you can say that at initially the insulin sensitivity was 100%, but as type 2 diabetes insulin resistance started increasing, insulin sensitivity goes on decreasing, and there is a like as the insulin sensitivity goes on decreasing, body increases its insulin secretion. As you can see here, as the sensitivity is going on decreasing, body increases its insulin secretion up to a point B where the islet cells get sort of exhausted, and insulin sensitivity goes on decreasing in diabetes. Insulin sensitivity will go on decreasing in diabetes as the disease progresses, and if it's not controlled by exercise and lifestyle changes and metformin, insulin sensitivity will go on decreasing, but body cannot make more insulin. If the body response expected response was that as the insulin sensitivity go on decreasing, the insulin secretion will go on increasing like this, but There is this point somewhere where insulin sensitivity goes on decreasing, but insulin secretion does not increase in the same proportion. In fact, insulin secretion decreases because the beta cells are now exhausted. And then this point C happens where there is impaired glucose tolerance before development of overt diabetes, where there is insulin resistance or decreased insulin sensitivity and also decreased insulin secretion, and that is impaired glucose tolerance. And insulin sensitivity goes on increasing further, and even the insulin secretion decreases further because the body is not able to compensate for the insulin requirements, and that is when at point D there is type 2 diabetes. So this was the pathogenesis, you can say, or the temporal mode of development of type 1 and type 2 diabetes. Insulin is secreted as pre-proinsulin, which is broken down to proinsulin. Proinsulin is converted to insulin C peptide, connective peptide. Half-life of insulin is 4 to 5 minutes. Half-life of C peptide is 35 minutes. Insulin and C peptide estimation is useful in separating type 1 from type 2 diabetes. C peptide is more reliable marker of insulin secretion due to longer half-life. You can see this beautiful diagram here where insulin is secreted as pre-proinsulin. This pre-proinsulin has a signal sequence which sort of directs the growing insulin chain into the lumen of the rough endoplasmic reticulum. And then that signal sequence is cleaved away from that, and we have a proinsulin. Proinsulin has the alpha and A and B chains of insulin and the C peptide, connecting peptide. Connecting peptide is actually responsible, or connecting peptide is actually essential for the insulin to fold into its final conformation. The A and B chains joined with disulfide bridges, that conformation of insulin is made possible by the connecting peptide. But connecting peptide does not have a role in physiological action of insulin. So even that connecting peptide, so this proinsulin is transported to Golgi where it is processed, and when it is about time for the insulin to be secreted out of the cell, it is packed from the Golgi into these transport vesicles, and in that it is cleaved into insulin and C peptide, and both insulin and C peptide are secreted together in the bloodstream. However, the difference is that insulin lasts only for, like, half-life of insulin is only 4 to 5 minutes, whereas half-life of C peptide is 35 minutes. That means C peptide levels will remain elevated for a longer time after secretion. And that is why C peptide is a more reliable marker of insulin secretion due to its longer half-life. If you want to distinguish whether this hyperglycemia is because of type 1 diabetes or type 2 diabetes, you do a fasting insulin C peptide level. If insulin also, more than insulin, the C peptide, if they are normal, that means insulin secretion is normal. So it is most likely type 2 diabetes. And if insulin C peptide are low, that means it is type 1 diabetes. This is again a diagram showing conversion of proinsulin to insulin with the cleavage of C peptide. As you can see, this C peptide kind of made it possible for the chain to turn like this, and then it just cleaved to give this insulin molecule. Who should be suspected for diabetes? Who should be suspected for diabetes? Clinical onset of diabetes can be sudden or it can be insidious over several years. Patients with the following symptoms should be tested. Classic symptoms of hyperglycemia are excessive thirst, polyuria, actually it is polyuria which causes polydipsia, and unexplained weight loss because muscles are not able to utilize the glucose in the blood. Visual blurring, maybe because of deposition of age in the lens, and retinopathy. Incidental finding of hyperglycemia or known impaired glucose tolerance. Complications of diabetes, like sometimes you may not know the person is diabetic, but in their routine tests you might find proteinuria or some neuropathy, tingling sensation, or lack of sensation of the sole of the foot, like heart attack, cardiovascular complications, ischemic heart disease, retinopathy. So if they suddenly, many diabetic type 2 diabetic patients can present with complications and their diabetes can get detected late. Evidence of dehydration, orthostatic hypotension, confusion or coma. What is orthostatic hypotension? If you are lying down on the bed and if you stand up suddenly, sometimes you may have noticed that you feel slightly dizzy, but that is not orthostatic hypotension. That is because when you are lying down, the vessels are relatively dilated, and when you stand up, the lower part of the body vessels have to constrict to maintain the blood flow to the heart so that the cardiac output is maintained. And that is an autonomic nervous system mediated reflex. But in diabetic patients, there is autonomic neuropathy. So that constriction of blood vessels of the lower part of the body, the inferior vena cava and the veins to push blood up into the heart, that doesn't happen. And so if these patients with long-standing diabetes, which was not detected, and they have autonomic neuropathy, if they stand up suddenly from a lying down position or especially lying down position, there will be a fall in BP of more than 10 mmHg. BP should fall more than 10 mmHg, and that decrease in BP of more than 10 mmHg lasts for more than a few seconds, so much so that they feel dizziness and visual blurring, fainting, etc. And they need to literally sit down again. So they can't immediately get up from a sleeping position. They need to get up like gradually. This is orthostatic hypotension. That is a diagnosis that can be a sign of diabetes. Confusion, coma because of hyperglycemia, hypoglycemia. Screening for diabetes, anyone over the age of 45 years, anyone who is overweight. So there is a difference. In the Western population, overweight is body mass index more than 25 kg per meter square, but for Asians, overweight is anyone who is more than 23 kg per meter square BMI. If there is family history of diabetes in a first degree relative, if there is habitual physical inactivity, if you belong to high risk ethnic or racial groups, it's almost everyone except the Caucasians, I believe, over here. History of delivering a baby weight more than 4.1 kg or history of gestational diabetes. In gestational diabetes, there is macrosomia and babies are generally large babies weighing more than 4.1 kg. Hypertension can be associated with diabetes. Dyslipidemia, which is defined as serum HDL less than or equal to 35 milligram per DL and or serum triglyceride more than 250. Previously identified impaired glucose tolerance or impaired fasting glucose tolerance or HbA1c in the pre-diabetic range. Polycystic ovarian syndrome predisposes to diabetes by increasing insulin resistance. History of vascular disease can be a harbinger of diabetes. Acute complications. So coming to complications, acute and chronic complications of diabetes. Acute complications of type 1 diabetes is diabetic ketoacidosis and type 2 is hyperosmolar hyperglycemic coma. So diabetic ketoacidosis is seen in type 1 diabetics. There is absolute insulin deficiency and unopposed action of counter-regulatory hormones on liver, adipose tissue and muscle, which leads to unchecked gluconeogenesis and lipolysis. And there is dehydration, fruity breath to the smell because it is ketoacidosis, there is ketosis, orthostatic hypotension, tachypnea. Generally, the breathing in diabetic ketoacidosis is called as Kussmaul respiration. The patient is seen like short, deep, rapid breaths, which are characteristic of diabetic ketoacidosis, Kussmaul respiration. And if you see a patient breathing like that, short, deep, rapid breaths, and with a fruity breath odor, it may be mostly type 1 diabetic ketoacidosis. Tachycardia, abdominal pain, nausea, vomiting, confusion, history of viral bacterial illness, trauma or emotional stress that was the trigger for development of type 1 diabetes. And a lot of the cases of type 1 diabetes are diagnosed for the first time because they present as diabetic ketoacidosis, and that is how they are diagnosed. And that is why this history is very important. In the labs, you will find hyperglycemia, which is around 300 mg per deciliter, glucosuria, ketonemia, ketonuria, low bicarbonate, elevated blood urea nitrogen, elevated creatinine, because it sort of causes acute kidney injury. And pH is less than 7.3. Matlab, this kind of acidosis is slightly more severe compared to hyperosmolar coma, which we will see. There is decreased total body potassium and phosphorus. Now, in hyperosmolar coma is seen in type 2 diabetes. It can lead to hyperosmolar coma. The degree of hyperglycemia and dehydration that develop is often far more severe in patients with type 1 than patients with type 1 diabetes. Hyperosmolar coma usually occurs in elderly patients with decreased ability to obtain free water precipitated by illness or drugs. If there is an elderly patient with type 2 diabetes, bedridden, and there is no one around, they can't even ask for water, and so this can happen in them. Decreased mentation, coma will happen, dehydration. Hyperglycemia is more than diabetic ketoacidosis. It is about glucose levels more than or equal to 600 milligram per deciliter. And because glucose is elevated so much, osmolality is also elevated, which is more than 320 milliosmoles per kg. That is why it is called as hyperosmolar coma. Normal osmolality of the blood is 275 to 295 milliosmol per kg. Bicarbonate remains more than 15 and pH remains more than 7.3. So acidosis is not that severe, but there is dehydration and coma, decreased mentation, and severe hyperglycemia. Although why it goes still here, because there is some insulin and counter-regulatory hormones effect is not so much. So blood glucose also increases and it causes all these complications. Coming to chronic complications of diabetes can be divided into microvascular and macrovascular. Microvascular are retinopathy, neuropathy, nephropathy, and macrovascular are mostly due to atherosclerosis. They can be CAD, CVD, PAD, coronary artery disease, cerebrovascular disease, peripheral arterial disease. How to screen for chronic complications in diabetes mellitus? Routine eye examination recommended once a year for macular degeneration or retinopathy. Routine foot examination for presence of sensation or ulcer. These, if there is sensation, loss of sensation, the diabetics may not realize that there is some injury to the foot, and that injury doesn't heal, and in fact it can grow and form an ulcer. Screening for microalbuminuria using urine dipstick for early detection of diabetic nephropathy, or you can just monitor serum creatinine yearly, right? At least a year for early diagnosis of diabetic nephropathy. So serum creatinine yearly is advised to monitor for diabetic nephropathy. Screening for coronary artery disease by assessing lipid profile, which like complete lipid profile with total cholesterol, triglycerides, HDL, LDL, VLDL, lipoprotein A, and inflammatory markers like CRP or hsCRP. Now, diabetic nephropathy and coronary artery disease are the most common cause of mortality in diabetics, especially type 2 diabetes mellitus. Retinopathy is the most common cause of blindness in diabetics. Peripheral neuritis, loss of food sensation leading to non-healing ulcer, is common microvascular complication, occurs earlier in patients with poor glycemic control. So these are my references for this presentation, and thank you so much.